The following presentation is funded in part by Centerstone. Hello, and welcome to this communication educational session on the impact of COVID-19 on brain health, presented by the Brain Health Initiative on behalf of Centerstone. I'm Dr. Shelley Carson, a Scientific Director of Research at the Brain Health Initiative, and also a psychologist, researcher, and lecturer at Harvard University's Department of Psychology and Continuing Education School. This educational session will be presented in 3 segments, addressing neurological symptoms and complications of COVID-19, mental illness symptoms and their prevalence during the COVID pandemic, and finally, steps we as mental health professionals can take to improve overall brain health and wellness in our own lives, the lives of clients and patients, and others in our community. Thank you for your interest in this topic. In this segment, we'll examine the interaction of pre-existing mental illness diagnoses and COVID-19. We'll also look at mental health consequences of both the virus and the pandemic at large. We'll see that pre-existing diagnoses of mental illness may increase the risk of contracting the virus and may also complicate treatment of the virus. The virus may increase the severity of mental illness symptoms, and mental illness may impact the severity of viral infection, the duration of infection, and the outcome of treatment. First, let's look at how a pre-existing mental disorder may increase a patient's susceptibility to the coronavirus. Previous research has indicated that mental illness poses susceptibility to infectious disease. In an examination published in 2008 of the records of over 47,000 U.S. college students, researchers from Arizona State found that the odds ratio of not getting an infectious disease for students without diagnosed depression or anxiety was between 0.56 and 0.91, depending upon the infectious disease involved. That is, the odds of having an infection increased substantially when the student reported depression or anxiety. Australian researchers compared 45 children who were susceptible to chronic upper respiratory infections to 45 healthy children and found that the susceptible children reported significantly higher scores on measures of childhood depression and anxiety. While not looking at depression per se, British researchers Susan Faulkner and Andrew Smith prospectively tracked negative mood over a 15-week period in a group of patients with chronic fatigue syndrome and a group of healthy controls, and found that negative mood was significantly higher in weeks prior to the development of upper respiratory tract infection compared to weeks prior to no infection. The authors conclude that negative mood states increase risk for susceptibility to respiratory infection. In an overview of previous research, Falagas and colleagues reviewed 44 published studies that associated psychosocial variables with increased risk for infectious disease, of which 4 studies pertained to higher anxiety levels and 12 studies pertain to increased perceived stress as risk factors for susceptibility to infection. Looking further into stress-related variables, PTSD is known to be related to immune system dysfunction. However, there are mixed findings as to whether PTSD increases vulnerability to infection. It is known, however, to exacerbate inflammation once infection is contracted. Alcohol use is known to have a dose-dependent response on the immune system, with moderate alcohol consumption actually improving immune response and protection, while long-term heavy misuse of alcohol, such as an alcohol dependence or alcohol use disorder, reduces the immune functioning and increases risk for infection. The impact of alcohol abuse on risk and severity of infection has been demonstrated in particular for infections of the respiratory tract, as demonstrated in a 2008 review by Zhang and colleagues. Because of the robustness of this past research, we have great concern that patients with pre-existing alcohol use disorders are at considerably greater risk than the general public for COVID-19. So to summarize, past research suggests we should expect that being diagnosed with a pre-existing mental disorder will increase an individual's susceptibility to COVID-19 infection. Although results are certainly incomplete at this time, here's what we know so far. Tackett et al. Analyzed data from over 62,000 patients who were positive for COVID-19 between January 20th and August 1st, 2020. Of this group, approximately 16,000, or 25%, were diagnosed with a pre-existing mental disorder. Having a diagnosis of psychiatric disorder in the year before the COVID-19 outbreak was associated with a 65% increased risk of COVID-19. The risk for diagnosis if a mental disorder was present was higher in older patients. The risk was higher if a psychotic disorder was present. Regarding alcohol, an interesting finding by Hamer et al. In a large population study of almost 400,000 adults in the UK was that alcohol consumption, even very heavy consumption, did not seem to be a risk factor for contracting the virus. However, alcohol consumption has been shown to have indirect effects on COVID infection. Drinking's already been blamed for several severe outbreaks of the virus where instances of heavy alcohol consumption in gatherings of people led to relaxation of appropriate safety precautions. We'll hear more about alcohol use disorder in just a minute. In a study published in Lancet Healthy Longevity, Chinese researchers used UK Biobank data to study over 50,000 patients with a psychiatric disorder diagnosis prior to January 31st, 2020, and over 370,000 people who did not have a psychiatric diagnosis before that date. They found that the pre-pandemic psychiatric disorders group had an increased rate of COVID-19 diagnosis over the next 6 months relative to the non-diagnosed group. The odds ratios were significant for a number of different disorders. Individuals who had a diagnosis of depressive or anxiety disorder were over 50% more likely to be COVID positive than those who did not have such a diagnosis. The odds for stress-related disorders, which included PTSD, acute stress reaction, and adjustment disorder, were almost as high. In fact, the odds ratio of getting COVID with any pre-existing mental disorder in this review was 44% higher than the odds of getting it without a pre-existing disorder. The researchers reported that the overall elevated risk of COVID-19 in individuals with pre-pandemic psychiatric disorders did not differ by sex, race, or ethnicity. In addition to increasing risk for infection with COVID-19, pre-existing mental disorders may affect the course and treatment of those who have already been infected. Research from prior to the COVID era indicates, for example, that depression may prolong symptoms and treatment of respiratory infections. A study by Lewis and colleagues in the UK followed over 100 patients who had been hospitalized for acute infections. Although there was no difference in the number of patients who were clinically depressed upon hospitalization, the number of patients who still had symptoms of infection at 3 months post-initial hospitalization were significantly more likely to have been depressed at initial hospitalization than those who did not remain symptomatic. Jumping forward to current research, we see that pre-existing mental disorders affect the severity of COVID infection. Atkins et al. Found that a diagnosis of depression was one of the factors that predicted hospitalization and eventual COVID-related death in seniors that had either contracted COVID-19 or died of COVID between February and April of 2020. In a study published in September in JAMA Network Open, researchers at Yale looked at over 1,600 patients in the United States who'd been hospitalized with COVID-19. 28% of these patients had a pre-existing psychiatric diagnosis before hospitalization. The group with psychiatric diagnoses had a statistically significantly higher death rate than the non-psychiatric control group, 36.8% versus 14.3% at 4-week follow-up. The psychiatric group was 50% more likely to succumb to death than the non-disordered group. Previous research indicates that alcohol use disorder increases the risk of being ventilated during serious illness. DeWitt et al. Looked at hospital records of over 700,000 patients and reported that alcohol use disorder increased the odds of mechanical ventilation during serious illness from 8% to 13%, while going through withdrawal from alcohol during hospitalization for serious illness increased the duration of ventilation from 57 to greater than 96 hours. Because of the increased rate of death of patients who are ventilated, it's important to reduce risks for ventilation. Several factors have led to increased drinking during the COVID pandemic, including social isolation, increases in depression, anxiety, and stress, and the myth that drinking is protective against the virus. Biomedical scientists caution that for those who contract the coronavirus, a history of heavy drinking can compromise lung function and lead to more severe symptoms, difficulty with breathing, and potential need for intubation. Even if heavy drinking does not increase the risk for contracting the virus, as we saw earlier from the Hamer study, it can increase the severity of respiratory symptoms. In a broader examination of the UK Biobank data, Wang and colleagues, mentioned on a previous slide, performed odds ratios on COVID-positive patients with and without psychiatric diagnoses. Those with certain mental illnesses were more likely to have serious manifestations of the virus, to be hospitalized, and to die of COVID-related deaths. In fact, in this study, the odds of dying of COVID was 2 times greater if the patient had a psychiatric diagnosis, and almost 3 times greater if depression was present. If we take a moment to think about what the accumulating data on pre-existing mental illness means in the COVID era, it appears that those with pre-existing mental illnesses are more susceptible to the virus and have a more serious course of the disease and greater risk for complications and death. The goals of mental health professionals, therefore, should be to emphasize COVID safety precautions for mental health clients, to minimize risk in other areas, to enhance their immune systems through self-care monitoring, and to ensure their mental health care is continued should they be hospitalized. Too often, there are reports that mental health care is overlooked in hospital in the face of more urgent physical care, when it's apparent that the two are mutually intertwined. Now let's turn our attention to the broader effect of COVID on world mental health. Here we can ask two questions. First, how does being infected with COVID-19 affect the mental health of COVID-positive patients in the aftermath of the illness? Second, how is the pandemic itself affecting the mental health of populations around the world? Regarding the first question, in a study examining over 62,000 people in the U.S. diagnosed with COVID between January 20th and August 1st, 2020, 18.1% of patients received a psychiatric diagnosis in the 14 to 90 days after COVID was confirmed. Anxiety disorders were the most frequently reported psychiatric diagnosis. For people over 65, the most frequent diagnosis was dementia. Many of these, according to the study's authors, are first-time psychiatric diagnoses. Huang and colleagues reported on a cohort of patients who had been treated for COVID-19 at Jinyintang Hospital in Wuhan, China, between January 7, 2020 and May 29, 2020, and then followed up in late 2020. Anxiety or depression was reported among 23% of the patients. Among those who had required ventilation or oxygen while hospitalized, the rate was 32%. 56 patients from this cohort had dementia or psychosis, which is about 2% of the discharged cohort. Speaking of ventilations, previous research has also shown that 35% of ICU survivors have clinically significant PTSD symptoms, even 2 years subsequent to ICU care. We're also understanding more about post-intubation syndrome. Once a patient is medically stabilized and survives the ordeal of the COVID virus, if they've been ventilated and in ICU, their ordeal is far from over. It's important to assess and provide care for mental illness responses like PTSD and depression that are common but not always considered by overtaxed hospital staff. Now let's turn to the pandemic and its effect on the mental health of the globe. Looking at our broad 30,000-foot overview, Zhang et al., in a multinational review of 19 studies representing over 93,000 participants, assessed the rates of major mental disorders in general population participants in countries across Europe, Asia, and North America. The rates varied according to study and country, sometimes varying widely. For instance, the rates for anxiety varied between 6.3% and over 50%. Depression rates varied from 14.6% to 48%. PTSD from 7% to over 53%, while general psychological distress seemed fairly consistent across studies and across nations, varying between 34.4% and 38%. Important in this report is that Zhang et al. Were able to collect information on risk factors for mental illness from across studies and countries. Risk factors included being female, being younger, having a chronic psychological disorder, being unemployed, being a student, and having greater exposure to information about COVID-19 on social media and news outlets. The Kaiser Family Foundation sponsored a study of older adults to determine the effect of the pandemic on their mental health. 1/4 of seniors reported symptoms of depression and/or anxiety. Women were more likely to experience either anxiety or depression than men. Younger seniors, between ages of 65 and 74, were more likely to be depressed or anxious than older seniors, those over 80. Older Hispanic adults reported anxiety and depression at higher rates than other ethnic groups. Those who lived in a household where someone had lost employment were more likely to be depressed than those who lived in a household with no employment loss. The Kaiser Family Foundation reports that these rates are considerably higher than in 2018, where 1 in 10 older adults reported anxiety or depression. In a snapshot of the U.S. mental health response to the pandemic, the CDC reported on 5,470 respondents to a June 2020 survey. Overall, 40.9% reported at least one adverse mental health condition, including symptoms of anxiety and depressive disorders at 30.9%, trauma and stress-related disorders at 26.3%, increased substance use at 13.3%, and the percentage who had seriously considered committing suicide within the past 30 days at 10.7%. Males were just as likely as females to report depression and trauma or stress-related disorders. Females were slightly more likely to report anxiety disorders, and males were more likely to report being suicidal. Younger people under the age of 24 were the most vulnerable, followed by the group from 25 to 44. The age groups over 44 reported lower rates of mental disorder. Rates of disorder and suicidality were highest, as in the Kaiser Foundation study, in Hispanic groups, followed by Blacks. The group with lowest risk was Asian. Other mental health consequences of COVID-19 pandemic include the implications for the current opioid epidemic. Unfortunately, overdose deaths due to opioids, in particular synthetic opioids, are increasing, and disruption in daily life caused by the pandemic is partially to blame, according to the CDC. Pandemic control measures, including quarantine or social isolation, and the scarcity of healthcare resources and staff, are issues that will challenge mental health professionals going forward. In addition to new and climbing rates of mental illness, people with existing mental illnesses may see a worsening of their condition, as Zhao et al. Found in their study of 2,065 Chinese outpatients. Suicidal thoughts have also been on the rise. Reinert et al. Report a spike in suicidal ideation in 2020 in the 2021 Mental Health America publication of last year's large survey results. Especially affected are youth, LGBTQ, Native American, and Black groups. A multinational team of researchers evaluated the mental health trajectory of patients from the previous SARS epidemic of 2002 to get a feel for what the future may hold for patients in the current COVID-19 pandemic. The rates of mental illnesses, including PTSD and depression and anxiety and psychosis, appear to be similar at the time of hospitalization in infection-positive patients to what we're seeing now. Rates of mental illness symptoms in the previous epidemic steadily declined over the first 12 months after patients left the hospital, but were still well above the rates of healthy individuals at 12-month follow-up. The researchers conclude that the mental illness symptoms of the coronavirus, if it follows the trajectory of its predecessor, will last longer than the physical symptoms. The scale, of course, of the current outbreak is far greater. We need to be prepared for not only the breadth, but the duration of the mental health crisis that is unfolding. Let's take a moment to consider the implications of the data we've just seen. Approximately 18% of American COVID patients will quickly develop anxiety and depression symptoms after their encounter with the virus. 23% of Chinese COVID patients have symptoms of depression and anxiety 6 months after COVID, and previous research indicates that the mental illness numbers will remain high for at least 12 months. As of this date, we have over 26 million diagnosed cases of COVID in the United States, so we could expect around 4,800,000 individuals with COVID-related mental illness alone. However, this number pales when we look at the pandemic numbers. Zhang et al. Estimates from 19 studies across the world all converge on similar percentages. Somewhere around 1/3 of the population of affected nations are experiencing psychological distress serious enough to be measured. We won't calculate the numbers. However, the need for mental health professionals is overwhelming right now. The world truly needs your skills and services. You are in the right place at the right time to make a difference. Before we close this segment, let's do a quick review. Both research from before the COVID era and current research indicates that pre-existing mental illness may increase the risk for contracting COVID-19. It's essential that clients with pre-existing mental illness take extra precautions against the virus. Drinking alcohol has a dose-dependent effect on the immune system. In small to moderate amounts, it appears protective. However, alcohol use disorder and alcohol dependence are associated with increased risk for respiratory infection and will likely compromise the immune system. Pre-existing mental illness is associated with increased severity of COVID-19 infection and with increased risk of death, especially in older adults. After experiencing COVID-19, the risk of depression, anxiety, and trauma and stress-related symptoms, indeed all types of psychological distress, is elevated across the globe. These findings suggest that mental illness and physical illness are deeply intertwined. As mental health professionals, one of the most important therapeutic practices we can implement today is to help clients stay free of the COVID virus. A complete list of all references cited in this segment accompanies this presentation. For more information on COVID-19 and its impact on brain health, please see these additional videos in this communication educational session. Thank you. I'm Dr. Shelley Carson.